Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. We are from Group 4 for Oral and Maxillofacial Medicine, and we're going to talk about migraine in dentistry. In this presentation, there will be 4 things that will be discussed. The first one is risk factor, second is clinical manifestation, third is management, and last one is for case report. My name is Dira. I'm going to talk about introduction of migraine in dentistry. The first one, we're going to take a look about definition of migraine. A migraine is actually a type of headache, and it may occur with symptoms such as nausea, vomiting, or sensitivity to light and sound. It can cause a severe throbbing pain or a pulsing sensation, usually on one side of head. So you might want to ask, what is the relation between migraine and dentistry? So migraine has been linked to a number of medical problems, and the most common of which are chronic pains like temporomandibular disorders, or we know as TMD. So migraine has the ability to imitate other forms of pains such as toothache and sinusitis, since it's regulated by branches of the trigeminal nerve. And as a result, oral and maxillofacial surgeons should always be familiar with the medical criteria for migraine headaches in order to identify and treat those patients who come to their clinics. Lastly, we're going to talk about the common dental issues associated with headaches and migraine. First one is bad bite, which is a missing or misaligned teeth created a bad bite and forces jaw muscle to work harder to bring teeth together, to swallow, and to keep the mouth closed. These will lead to the migraines and also headache because they feel pain. Second is grinding or clenching teeth. It also can cause muscle and gum inflammation, thus triggering migraines and also headache. Last is tooth decay and gum disease, or we call as a caries or periodontal disease. This is a throbbing toothache and also can lead to triggering a migraine episode or a headache. That's all from me. Moving on to the risk factors.
Assalamualaikum warahmatullahi wabarakatuh. My name is Sarfina. I will explain about the risk factors for migraine. These risk factors basically related to migraine chronification, which is a process that describes the developments from episodic migraine into chronic migraine. So, you may want to know what is the difference between episodic migraine and chronic migraine. Episodic migraine is defined as less than 15 headache days per month. Meanwhile, chronic migraine is defined as neurological disorder characterized by 15 or more headache days per month, of which at least 8 days show typical migraine features. The risk factors can be divided into 2 categories, which are non-modifiable risk factors, mainly include socio-demographic features, and modifiable factors, which can provide targets for intervention. For non-modifiable risk factors, there are 4 risk factors, which are: first, gender. Chronic migraine prevalence is 3 times more common in women than men. Additionally, according to the American Migraine Prevalence and Prevention Study and the International Burden of Migraine Study, both episodic migraine and chronic migraine are more common among women and young adults. Second non-modifiable risk factor of migraine is age. According to Journal of Head and Face Pain, a pattern of increasing chronic migraine prevalence with age from 18 to 50 years old has been observed for both males and females. The highest prevalence of migraine occur between 2nd and 5th decade of life, which is the period of time of the most productive years of individual's life. Third risk factor is genetic, that play important role in migraine. According to Roderick Spears, a medical director of neurology at Penn Medicine in Pennsylvania, if family members have migraine, the person may have about 75% chance of having first-degree relative with migraine. It can be passed equally from both the mother's and the father's side. Family history is particularly important in migraine with aura. In migraine with aura, a person may experience visual, sensory, or speech-language symptoms for several minutes up to an hour, usually followed by a headache. Visual symptoms may include flash of light or temporary vision loss. Sensory symptoms can include numbness and tingling, and speech-language symptoms include difficulty speaking. Lastly, low socioeconomic status. Research published in Cephalalgia found that women with lower socioeconomic status had increased risk of migraine and increased risk of more frequent migraine attacks. Modifiable risk factors of migraine. There are 6 risk factors, which are: first, medication overuse, which is a powerful risk factor for the development of chronic migraine. Among overused drugs, including opioids and barbiturates, which are associated with dose-dependent increased risk of new onset chronic migraine, while triptans induce migraine progression only in those with high frequency at baseline, but not overall. Non-steroidal anti-inflammatory drugs, NSAIDs, protect against migraine progression unless individuals have 10 or more headache days per month. Second, comorbid pain such as psychiatric, neurological, and medical comorbidities. Prior studies have found that migraine occurs together with other illnesses at a greater coincidental rate that is seen in the general population. These occurrences are called comorbidities, which means that these disorders are interrelated with migraine. There are multiple psychiatric comorbidities associated with migraine, including depression, anxiety disorder, personality disorder, and bipolar disorder. Migraine also linked to many neurological comorbidities, including epilepsy, ischemia, stroke, cardiovascular diseases, and sleep disorders. There are also several medical comorbidities associated with migraine, including asthma, allergic rhinitis, cardiac disease, and non-headache pain disorders include temporomandibular disorder. If untreated, these comorbidities can increase the risk for migraine chronification and migraine-related disability, leading to a decrease in the quality of life and adversely affect the treatment outcomes. Third risk factor is stress. Major life changes, such as changes in work, relationships, or residence, illness, or death of family member or friend can exacerbate symptoms and headache frequency, increasing the risk of chronification. Modifiable risk factor is poor sleep quality and sleep disorders. The Chronic Migraine Epidemiology and Outcomes study shown that chronic migraine patients more frequently reported sleep apnea or were more likely to be at high risk for sleep apnea than episodic migraine patients. Chronic migraine patients shown poorer sleep quality compared to episodic migraine patients with higher rates of sleep disturbance, snoring, and shortness of breath. Some physiological changes such as fluctuations in intracranial and atrial pressure during snoring and increased muscle activation during awakening may underlie this relationship. It may be severe in persons with higher migraine day frequency. Next, according to Nada Hindeh, a headache specialist and researcher at Stanford Healthcare in Palo Alto, California, changes in hormone levels is very common for women to get migraine around their menstrual period. The drop of estrogen hormones play a significant role in the expression of migraine. Menstrual migraine is defined by the International Classification of Headache Disorders as migraine attacks usually occurring on day 2, which is 2 days prior to menstruation to 3 days after menstruation in at least 2 out of 3 menstrual cycles. Last but not least, excessive consumption of caffeine may contribute to the onset of a migraine attack. Some people find that suddenly stopping caffeine altogether can also be a trigger factor. Abrupt withdrawal of caffeine in individuals with chronic migraine is associated with rebound headache, further supporting the importance of this substance as a risk factor. Some people find that consuming less caffeine at the weekend can have an impact on migraine attacks. But we should also take note that caffeine can be found in many products, including chocolate and over-the-counter, which is the painkillers. That's all for the risk factor of migraine for me. Thank you.
Hello, I'm SYAZWANI. So let's move on to clinical manifestation. Clinical manifestation can be divided into 4 stages, which are prodrome, aura, attack, and postdrome. For the first stage, which is prodrome, it is the first warning signs that occur 1 to 2 days before a migraine. The second stage, which is aura, it is also called as cut migraine. It shows a reversible symptom of the nervous system. The third stage, which is attack, it might occur rarely or strike several times a month. It can be last for hours to days. The last stage, which is postdrome, it is also called as migraine hangover. It can be few hours to more than a day after the headache goes away. To make it more clearer, every stages show different symptoms, but have to note that the symptoms vary from person to person. For the first stage, which is prodrome, the person may experience constipation, mood changes, food craving, neck stiffness, increased thirst and urination, and frequent yawning. For the second stage, which is aura, the person may experience visual phenomena, vision loss, pins and needle sensation, weakness or numbness in the face or one side of the body, difficulty in speaking, hearing noises or music, and uncontrollable jerking or other movement. The third stage, which is attack, the symptoms under attack are pain, usually on the one side of the head, but often on the both sides, pain that throbs or pulses, sensitivity to the light, sound, and sometimes smell and touch, followed by nausea and vomiting. The last stage, which is postdrome, the person may experience tired, unable to concentrate, general in bad mood, strain and watch out. For the physical symptoms, the person may experience gastrointestinal problems, weakness, neck stiffness, sensitivity to the light, and nausea.
For management of migraine, there are 2 treatment purposes. The first is acute therapy, and second is preventive therapy. Acute therapy is to reverse or at least stop the progression of the headache that has started, while preventive therapy is to reduce the frequency and severity of the migraine attack and make acute attack more responsive to abortive therapy. As we know, everyone has faced migraine. Treatment is proven to overcome it, but it is also important to manage it by personal management, as this occurs all of a sudden. Understanding to cope it can help to promote good mood and reduce frequency of the migraine and save your time too. Combination medication and good lifestyle are proven to counter the migraine, but somehow the medication take may cause some side effect too. That's why we need to know how to handle it by personal action. So there are 5 steps to relieve the migraine. First is find calm environment. As we know, migraine relates with surrounding. More conditions happen in the noisy place. Turn off the light when you are going to the bed, as migraine is sensitive to the light and sound, and it helps to relax your brain activity. Next is try temperature therapy or naturopathy therapy. Natural therapy is a system that uses natural remedies to help the body heal itself, including herb, massage, exercise, and nutritional counseling. For example, apply hot and warm pack to the head and the neck to relieve the pain sensation, where this can help to relax tense muscle. Drink a caffeinated beverage with small amount. It can also lead to migraine when you consume more than exact value. It can be used to reduce the migraine in the early stage by enhancing the pain-reducing effects of acetaminophen and aspirin. Fourth is take good sleep quality by establish regular sleep. Try manage your sleep time, 8 hours per day of taking naps above 30 minutes during the day because it can interfere your nighttime sleep. Unwind at the end of the day with something interesting like listen to the music or read the book to get better sleep. For some people having the nausea, such as medication or asking a doctor to prescribe the drug, either it have effect on the sleep time. Some drug contain caffeine or other stimulant vasodilator. Try avoid this if you can. For example, oral contraceptive will reducing the estrogen level in the body for female is a hormone aid to block the initiation of the pain in the brain that may alter your sleep quality. Next is eat wisely. Eat wisely also can help to reduce pain sensation or migraine attack. Be consistent taking your meal every time with good nutrient for body. For example, ketogenic diet, which high fat, low carbohydrate, and protein-filled diet can help to relieve the pain. Avoid food that trigger your migraine. Monitor your diet and avoid any ingredient that you're sensitive to, like chocolate, MSG, and caffeine. Thiamine is a biogenic amine that accumulate in food as it ages and may provoke migraine, such as cheese, vinegar, and some type of the bean. Next point is do exercise regularly. When you do exercise, you release certain chemical hormone called serotonin or happy hormone that help to block the signal or the pain signal to your brain and also aid to alleviate the anxiety and depression also. For patients that have hyperglycemia or obesity, it is a risk of the chronic migraine where blood may compete with the glucose in the vessel and alter the blood delivery to the brain. So you can avoid it by do exercise about 50 minutes and take a good diet. Lastly is manage your stress. Generally, the stress can lead to migraine too. It is important to you to manage it properly by manage your time wisely. As a student, you may have a difficulty to manage your time with many things to do. So try make note what to do every day and start with do the tasks that are important first. When you feel stressed, try to take a break by doing anything that you like, such as do few stretchings and quick walk to renew energy. Enjoy yourself by playing some video game as it can release serotonin hormone too.
Hi, my name is SHAHRUL. Now I am going to explain to you guys how we could differentiate between migraine and headache. There are a few types of headache, but the most common type of headache is tension headache. Tension headache commonly affect adults worldwide. It can be triggered by stress, tension, anxiety, and also can be due to the muscle strain. Tension headache has close clinical manifestation with those in migraine. That's explained why some doctors misdiagnose their patient of migraine with headache. So how to tell the difference? We can focusing more on the difference in location, duration, and sensation of the pain. Other type of headache are cluster headache and sinus headache. Here I include the table that illustrate the difference between migraine and tension headache. First, we can see that tension headache occur bilaterally, which is both sides of the head, while migraine can only occur unilaterally, which is one side of the head at one time. Tension headache appear as aching or dull pain, while migraine appear as throbbing pain or intense pulsing. The scale of pain for tension headache is mild to moderate pain, while for migraine is moderate to severe pain. Tension headache is non-recurrent, while migraine is recurrent. Tension headache can last for a few hours or days, while migraine can last for days. Tension headache may appear with tenderness of shoulder, neck, and head, while migraine may associate with nausea, dizziness, vomiting, temporary vision loss, sensitivity to light and blind spot. So this is the difference on how we could differentiate between migraine and tension headache. Next, we go to the case report of migraine. This is a case of a 22-year-old female who came to her dentist and she complained of the pain on her left jaw about 2 months prior, and also she experiencing difficulty to open her jaw. She described the quality of her pain as a dull ache. Next, we go to the case history. The past medical history documented that she began to experience significant headache about 5 years ago. Her attack usually began with a throbbing sensation in the left eye and nose. Of note, she denied nausea or vomiting associated with this attack, but she experienced photophobia and phonophobia during attack. She reported that her headache episode occurred monthly and lasting about 2 to 3 days. About 2 months prior to that, the pain became continuous and spread to the ipsilaterofacial region. Next, we go to the examination. Palpation was performed on the patient's left jaw. Upon examination, tenderness in the patient's left deep masseter and temporalis muscle were located. However, TMD evaluation revealed a normal range of mandibular motion and no disc problem in the left temporomandibular joint. Plus, intraoral and extraoral examination was negative for pathology.
Next, we move to the investigation for this patient. A panoramic X-ray was taken which did not reveal any dental or alveolar pathology, and also an intraoral examination was negative for dental, alveolar, and soft tissue pathology. What is the diagnosis for this patient? A preliminary diagnosis shows that there is a myalgia or muscle pain of left masticatory muscles. For differential diagnosis, we have headache disorder, intracranial pathology, and orofacial pathology. Subsequently, she was diagnosed as having migraine without aura, in which this migraine accompanied by anxiety, depression, or fatigue that generally sets in several hours prior to the headache pain. In absence of an aura, some people who experience this type of migraine may have other warning signs such as feeling thirsty, sleepy, or even craving something sweet. This is the treatment plan for this patient. First, she was given a home care instructions for treatment of a myalgia, including moist heat application and jaw stretching exercises. Next, she was referred to a neurologist for the further evaluation of her headache and facial pain complaints. Then, her physician prescribed her with 50 mg of sumatriptan, in which this drug is used to treat migraine headache. PRN here means that the administration of medication is not scheduled. Instead, the prescription is taken as needed. Her physician also prescribed her with 10 to 30 mg of nortriptyline, in which this drug is a tricyclic antidepressant and used to treat symptoms of depression. HS here means that this drug should be taken at bedtime. I think that's all from our crew. Thank you very much for listening.